Chapter 34, Geriatric Emergencies. So the great thing about this chapter, it's all review. All the content that this chapter has been dispersed evenly throughout the book and placed among the varying chapters where it's applicable. So anything that is cardiac specific in regards to our geriatric population, you'll find that in the cardiac chapter. Same with respiratory and everything else. So as we go through this, it should be primarily review for you. We'll touch on just a couple important things to focus on, but other than that, nothing here should be surprising to you. So something to think about, after age 30, and remember that everybody's different, right? This is a generality. But after age 30, we start to lose about 1% of overall organ or body function every single year. So in theory, what that means is that at 70 years old, we've lost roughly 40% of our overall organ function. Now, we all know that that seems kind of a little odd to think about, and it's certainly not the case with everybody. There's some people that have great health and organ function well up until 80s or 90s, and there's others who don't make it out of their 50s or 60s. So this is a generality. We can't walk up to somebody at age 70 and just assume that they're at 40% organ dysfunction. What we need to do is look at their underlying medical history, any previous diagnosis, medication, stuff like that, and that'll kind of give us a determination as to what their underlying health may be. But generally speaking, throughout age, we see a general decline in things like respiratory rate and heart rate. And the main reason for that is the fact that our metabolic rate decreases with age. So as a newborn baby has a pulse rate of approximately 150 and a respiratory rate in the ballpark of 50, throughout life that progresses downward. And we'll see elderly patients who have a resting heart rate probably around 60 to 70 and a respiratory rate probably closer to 12 or 14. Now, there's a lot of things that influence that, right? Those are natural underlying vital signs that would be unaffected by any other medical conditions, medications, things like that. And that's what we start to run into is in the elderly ages, we have a lot of medications and medical conditions that tend to influence what the body should be doing or what we think it should be doing. Along with internal organ changes, we also start to see challenges with basic communication. And that makes things relatively difficult for us. Trying to obtain an accurate medical history or sample history from a patient who has dementia or something like that may be challenging. Obviously, communicating with a patient who is hearing impaired, that presents its own set of challenges. So these are all things that, again, we just need to kind of identify when we get there. When we talk about surveying the scene, it's also surveying our patient. What is it that we need to do to adapt our assessment approach in order to make the best out of what we have to work with? With altered mental status, it may be relatively common, but don't assume that. I've got a 97-year-old grandmother who's sharp as a tack. So we need to, again, go in there, ask questions, and kind of determine either from bystanders, from medical records, whatever, what is the baseline mental status? And I think in most cases, you'll find that your elderly patients will be able to talk and communicate with you just fine. All right. So scene size up and safety, we'll do everything that we've always done, but we'll add a couple additional things in there just to kind of help us identify what could be going on. We look for the patient's ability to care for themselves, especially if they're living at home. It's got examples here of half-eaten food, a dirty house, or something like that. Now, some of us may live in homes that are spotless. Some of us may live in homes that are pigsties. None of that necessarily has anything to do with our ability to care for ourselves. But if you do see things that are kind of just out of sorts and you think that are relatively peculiar, not compared to how you choose to live, but what you think is generally acceptable within society, these are all things that we need to take note of, and it may be appropriate to report it to senior services. Now, let me provide one story or example on that. We had an elderly woman who lived in an apartment by herself. She had her dog with her. And we would go there every so often for a lift assist or something else. She'd hit her medical alert pennant. We get there, and the department was disgusting. And it wasn't disgusting by my standards. It was just plain disgusting by anybody's standards. Unkept, moldy food on the counters. There was fecal matter from both her and the dog spread throughout the apartment, urine, a whole bunch of stuff. It was just downright disgusting. And we would talk to her and ask her, does she have somebody that's able to help her clean up the house and everything else? And she just never seemed very concerned about it. So we ended up reporting her to senior services, feeling that she was unable to care for herself and that she was a threat to herself and potentially to anybody else that would come into the apartment. And senior services investigated, and they followed up with me a period of time later. And essentially what they said is, you know what, she's alert, she's oriented, she's decisional. Although, yes, we agree that those living conditions are disgusting, that is her choice, and there's nothing we can do about it. And that's what it came down to. She chose to live that way. It wasn't because she was unable to care for herself. It was because she chose not to care for herself. And in that situation, there's nothing that we can do to mandate it. Now, that same circumstance, though, had a child been in there, since a child is unable to choose for themselves whether or not they want to live in that type of condition, that would not be acceptable for children. So if we noted those types of conditions and a child was residing there or even visiting on a regular basis, then that would be an appropriate report to DCFS, and DCFS would probably feel slightly different than senior services did in that situation. So our primary assessment should remain the same. Nothing really changes there. And as we go into the secondary assessment, a couple considerations here. The history may be extensive. The med list may be extensive. So gather as much as you can in a reasonable amount of time. We could stay on scene talking about medical history for 30 minutes. That doesn't necessarily mean that it's appropriate. Sometimes you may need to narrow it down and say, what pertinent medical history do you have? What do I need to know about in order to provide treatment or care for you today? The fact that they had their wisdom teeth out when they were 9 years old, or they had their appendix out when they were 18, those things really aren't relevant to us when we're dealing with a patient that's 80 years old. Our head-to-toe assessment, again, will be no different than it is with the adults, with a general-aged adult. Certain things that we may observe, though, would be indications of elder abuse, depending on who they live with. Looking at things like bed sores, bruises of varying ages of healing, those types of things. But we're also going to look for the possibility that, they could have diseases that allow bones to break relatively easily and dislocate even. So we'll go and we'll look for those types of things, and that may not be necessarily from falls or trauma. It could just be natural occurrences. Obviously, in the instance of trauma, we want to take extra precautions here. As organ function decreases with time, that includes things like the central nervous system and the peripheral nervous system. Specifically, they're unable to interpret pain the same. Patients who have diabetes, that impacts the nervous system. They're unable to interpret pain the same. So somebody who generally doesn't have much in the way of complaints doesn't mean that they're not injured. It could just mean that they're not feeling it or the sensing it. So we still have to do full comprehensive assessments on these patients. There are things with age that could present. Now, this isn't specific to elderly patients. I honestly don't know why they just decided to put this slide in here. But the shingles is something that if you've ever had the chickenpox, you have the shingles virus inside you. It's just a matter of whether or not your body can fight it off from time to time. I know people in their 20s that have had shingles. I know people that are much older that have had shingles. And while this is generally not going to be a life-threatening issue, I know it is very painful from what I've been told. And then obviously we'd see things like rashes there. Now, for us as a pre-hospital provider, if we observe something like this, we could assume that it's shingles, but we still need to take general precautions as if it could be something worse or contagious, right? So take appropriate BSI precautions in these situations. The pelvis is going to be one of the more fragile areas of the body, especially when we're dealing with falls in our elderly patients. Their bones become brittle, they tend to break a lot easier, and pelvic injuries, hip dislocations, those are some of the most common injuries that we'll come across. These are extremely painful for the patient. So again, if pain medication is necessary, it may be appropriate to contact ALS to assist with these types of patients. Edema and swelling is something else we could be looking for, similar to discussions about congestive heart failure in the cardiac chapter. Patients, obviously, as they get older, are more susceptible to cardiac issues, including CHF. So looking for the presence of that edema may help us determine whether or not their CHF is acting up or not. Curvature of the spine and other deformities are common as people get older. So when we immobilize people, it may be necessary to pad them, maybe even sometimes place them on their side, depending on how bad the curvature of the spine may be. But we just need to, again, identify these types of things and build that into our treatment plan. Reassessing at a more frequent interval may be appropriate as well. These patients can change or decline relatively rapidly. Their compensatory mechanisms are not nearly as astute, I'll say, as general adults in their younger years. Beyond that, then, we'll monitor all other vital signs and ABCs as we would every other patient. No changes there. Let's see, we've talked about the trauma. Compliance. So with compliance, one thing that we need to know is not simply what the patient is prescribed to be taking as far as medications go, but are they compliant? Are they taking them, period? And are they taking them when they're supposed to? Are they taking the appropriate doses? So it's always appropriate to not simply ask about a medical history, but also look at the medication containers at the patient's home. Take a look to see, does it look like they're taking them, look at the date it was filled, how many pills are supposed to be taken each day, and try to get an estimate of how many should be remaining. And that's going to be a good way to determine if a patient is compliant or not. If a patient has a history of hypertension and they're non-compliant in their beta blocker, and they're sitting at a blood pressure of 174 over 98, okay, that could simply just be because they have hypertension, they're not taking their medication. But it could also be an indication of stroke or some type of intracranial issue. So we need to try to identify, are they taking their meds? And if so, is this related to something different? Drug interactions, obviously, we'll ask about allergies. Beyond that, though, we're not going to know much in the way of interactions as far as what can work with certain medications that our patients take. Our protocol books have an index in the back for all of our drugs that we use, and it'll call out any life-threatening or any serious interactions with other medications. But generally, the medications that we carry and use have very few interactions with other meds. One example may be nitroglycerin utilized with erectile dysfunction medication, right? That would probably be a great example of something that we really do need to be aware of, but beyond that, it's relatively uncommon. This, on the other hand, is common when we're looking at the nightstand or the bedside table of an elderly person. Their bathroom may look like this, their kitchen may look like this, makes it very difficult. They're going to have medications that they were prescribed in the past, but now their doctor told them not to take it anymore, but they never throw them out because what if they need them again? These are all things that we tend to run into, and it makes it difficult for us to get an accurate assessment of what their medications are and what type of history they have. Shortness of breath, although a very common complaint among all demographics of patients, we're going to really presume that this is going to be cardiac in nature. Even though the patient typically will have some type of respiratory ailment, because they have a decreased ability to sense pain, chest pain is not always a common presentation in cardiac events. So with these patients, we want to be sure that we are always being aggressive in acquiring EKGs, making sure that we rule out any type of underlying cardiac event. And then from there, we'll still go ahead and look into the respiratory component and treat it as necessary with oxygen or other medications. Chest pain, this is no different here. I'll give you an example from a AAA that I had not too long ago. A gentleman was just complaining of lower back pain, said his back was sore. He lived in an assisted living facility. They provided him with an ice pack and told him to go ahead and just go rest. Unfortunately, that turned into a AAA, and I don't know what the outcome was, but I know he was in pretty rough shape by the time we got to him. Altered mental status can be attributed to any number of things. Aside from our general medical conditions that we've covered throughout the semester, also throw in the components of dementia, Alzheimer's, or something like that. Abdominal pain and GI bleeding. If these patients are on an aspirin regimen or if they are on a prescription blood thinner, we have to be very aware of the potential for an increase or a GI bleed and the risk factors of them actually bleeding out internally. So not simply just their complaints, but also any medications that they're on. Those things are all going to come together to help us determine what are the potential consequences or what are the potential underlying causes for this patient's condition. Dizziness, weakness, and malaise, I'm always going to attribute that back to cardiac until proven otherwise. So again, any general complaints of new onset dizziness, weakness, anything else, I want to get a good set of vital signs, assess the blood pressure, general cardiac output, and also acquire that EKG. Depression and suicide is definitely a thing with this elderly demographic. We've talked a little bit about this in the past. I think the lifespan development chapter we talked about this, but we'll see a higher quantity or a higher volume of suicidal threats and even attempts in the teen years, right, in the adolescent years. However, we'll see a fewer number of attempts, but a much higher success rate in the elderly years. So what that means is that we've noticed that in the the adolescent years, the number of threats and attempts is higher, but the number of successes are relatively low as a ratio. And the reason being because these things are more often than not cries for help, right? They're trying to get the attention that they need in order to get some of the help that is required. Conversely, in these elderly patients, they don't want attention or help. When they've decided to commit suicide, then they commit suicide. And they usually have a way of doing it that's relatively foolproof, and they execute. So although, again, the number of attempts are relatively low, the corresponding number of successes as a ratio is much higher in the elderly demographics. All right, we've talked about that. Falls, with a fall, any type of trauma, car accident included, we want to know more than just the fall. What caused the fall? Is this an underlying medical condition such as a stroke or a heart attack that caused the patient to fall, or did they simply trip on a rug or extension cord or something else? But at the same time, did the fall then trigger a medical issue? Could the fall have knocked a blood clot loose? Could the fall and the ensuing anxiety that came from the pain, could that trigger a respiratory issue? So we have to make sure that we're always looking both at medical and traumatic components of any type of fall. Elder abuse and neglect, we'll look for the same signs and symptoms that we've talked about in the past. And just remember that if we identify any of these things, then we need to report them either to the police and or to senior services. All right. I think those are the relevant things that I have something to add on. Yeah, that takes us to the end. So that was a short chapter. Again, all of it should be review. The slides I skipped over, I didn't skip over because they're not important, but because you should either A, be able to read over those on your own, or B, should be a review from previous chapters. We'll see you in class, and have a great rest of your day.